Transplants are life-saving, but they also set the stage for one of the immune system's most intense battles. The USMLE loves transplant rejection because each type has a specific timing mechanism and histologic pattern. Learn these and you will crush every question they throw your way. Let's start with the fastest one, hyperacute rejection. This happens within minutes of transplantation. Why? Because the recipient already has preformed antibodies, usually against ABO blood group antigens or HLA antigens. It is a type 2 hypersensitivity reaction. Antibodies bind to the donor endothelium, activate the complement and causes widespread thrombosis and ischemia. The graft turns cyanotic mottled and dies immediately. Prevention: careful cross-matching before transplant. Next is acute rejection. This occurs weeks to months after transplantation, but it can also show up earlier if immunosuppression is reduced. So mechanism: cellular and humoral mechanisms. In cellular, CD8 T cells directly attack the donor cells, while CD4 T cells secrete cytokines to recruit the macrophages and inflammation. In humoral, the recipient develops antibodies against donor antigens after the transplant. Biopsy shows interstitial lymphocytic infiltrates, and the graft may show signs of vasculitis or mild damage. This type responds to immunosuppressive therapy, especially steroids and calcineurin inhibitors. Now comes chronic rejection. This is a slow progressive deterioration that occurs months to years after transplantation. So the mechanism? It is a mixed type 2 and type 4 hypersensitivity involving both antibodies and T cells. But instead of killing cells directly, this reaction leads to fibrosis and arteriosclerosis. Each organ has a specific pattern. In kidney, interstitial fibrosis and tubular atrophy. In lungs, bronchiolitis obliterans is seen. In heart, accelerated coronary atherosclerosis, and in the liver, vanishing bile ducts. The damage is permanent and usually leads to graft loss. And then we have graft versus host disease, a totally different story. This happens in bone marrow transplants or liver transplants that is rich in immune cells. In this case, it is not the host rejecting the graft, it is a graft's T cell attacking the host. GVHD primarily targets the skin, causing rashes, or GI tract causing diarrhea, or the liver. You see elevated enzymes here. The key phrase: the donor T cells attacking host antigens. It's a type 4 hypersensitivity reaction and it is a high yield concept. Now let's match the type of rejection to its buzzwords. Hyperacute. It occurs within minutes, preformed antibodies, type 2 and vascular thrombosis. For acute rejection, weeks to months, T cells and antibodies, treatable. Chronic rejections, months to years, fibrosis, arteriosclerosis, irreversible. And finally, GVHT. Donor T cells attack host, affect skin, liver, GI and type 4. Rejection is all about timing and immune mechanism. Know the both and you won't miss a single transplant question on step 1. You are almost through immunology. Let's lock in the final chapter, chapter 18, immunologic blood transfusion reactions. And I'm Dr. Ram here signing off.